Hello, and welcome to the Clinical Care Options Oncology Podcast. I'm your host, Tim Quill. Today's episode features Dr. Ashley Leak Bryant, Associate Professor at the School of Nursing at the University of North Carolina Lineberger Comprehensive Cancer Center. She will be discussing treatment strategies for lower-risk myelodysplastic syndromes, including key clinical trials and nursing considerations for supportive care. This episode is part of a larger educational program titled NEDTalk 2021, Current Therapeutic and Supportive Care Strategies for Myelodysplastic Syndromes. For more information on Dr. Bryant, along with a link to the complete program, including a downloadable PDF covering the topics discussed in this podcast, please visit the show notes for this episode. Now let's get started and hear what Dr. Bryant has to say.
So what is MDS? MDS is a spectrum of blood cancers in which many patients are asymptomatic. And as we know, as the disease progresses, the bone marrow function declines, often resulting in myelodepression. So what are some of the clinical manifestations that you've probably have seen within your clinical setting? Some of these patients come in with asymptomatic disease. Oftentimes they're diagnosed after one or more cytopenia during their routine lab draws. And then over time, then we do a prompt diagnostic workup that includes a bone marrow biopsy. There's another subset of MDS patients with cytopenias that present primarily with anemia, neutropenia, and thrombocytopenia. And we'll talk more about what those common signs and symptoms are. The IPSS-R prognostic score value is an important feature of managing MDS. And so we know that with this scoring system, it's used to assess risk. And we consider low MDS anything that is less than 1.5 to 3.0. So what is the criteria to guide treatment selection for someone with lower risk MDS? We think age and performance status is critically important. And as we know, oftentimes people with MDS are older adults, and their performance status or their functional well-being may either be at a fit or unfit level. It also depends on the number and the depth of the cytopenias. As I mentioned before, the depth of their myelosuppression, which includes thrombocytopenia, neutropenia, and anemia. How often are they needing transfusions? What is their karyotype? What is their erythropoietin level? So it's important to know what their baseline measures are and really monitor that trend over time. And then what other chronic conditions do they have, such as chronic kidney disease, high blood pressure, arthritis that may impact our treatment selection. So low risk MDS, what's our approach to treatment for someone with lower risk that's asymptomatic? Oftentimes our goal is to observe them until progression or symptoms play out, in which we say we really need to then move forward to treatment. And then we have lower risk symptomatic. And with that, there are really 5 options. Anemia with RS and ESA failure. And so our option there would be Luzedapret. We have anemia, and with the deletion 5q, thalidomide. Another lower risk symptomatic, someone with anemia, potentially some ESAs. Other anemia, we may consider thalidomide or an HMA, hypomethylating agent, or supportive care alone, or other cytopenias, we may even consider some growth factors. So it's also important here, I think, this last bullet, to consider clinical trial enrollment and supportive care for all patients and risk stratification using the scoring system that's supplemented by molecular testing. So it's important to think about, is this person even eligible for a clinical trial? The study that has received lots of attention over the past few years is the Myelodysplastic trial, in which it was an international randomized, double-blind, placebo-controlled phase 3 trial that focused in lower risk MDS. So it's placebo versus luspatercept patients who were greater than 18 years of age with non-deletion 5q MDS and ring sideroblast criteria. They had a very low or intermediate score, refractory, intolerant, or ineligible for any kind of ESAs, or if they were red blood cell transfusion dependent. Then they were randomized into 2 groups. We have luspatercept group, and then we have the placebo group. And the primary endpoint was someone who was red blood cell transfusion independent for greater than 8 weeks, between weeks 1 and weeks 24. And the secondary endpoints or red blood cell transfusion independent for greater than 12 weeks between weeks 1 and weeks 24. Luspatercept reduces transfusion burden and MDS-related anemia in lower-risk MDS patients. Also, let's think about the safety. With luspatercept, that common safety concerns were fatigue, diarrhea, and in the placebo, primarily it was fatigue and asthenia. And 4 patients progressed to AML during this trial, 3 in the luspatercept arm and 1 in the placebo arm. And we also know that the most common grade, greater than 3, of adverse events were anemia, fatigue, and falls. Another trial was the MDS 004, which looked at lineberger versus placebo in patients with lower risk deletion 5q. This was a double-blinded, randomized phase 3 trial that looked at the transfusion-dependent patients. The most common grades that were greater than 3 of adverse events were neutropenia, thrombocytopenia, leukopenia, anemia, and even DVTs. For MDS lineberger dosing, we say it's 10 milligrams a day. The most common adverse events include really your myelosuppressions with some GI concerns, even peripheral edema, coughing. Dose interruptions and dose reductions are used to manage treatment-related cytopenias, which we know will happen. We also know that dose reductions are required for patients with poor kidney function. So we're closely looking at the creatinine and BUN levels. And there's a box warning about embryo fetal toxicity and hematological toxicity. So with that being the case, for those who will be taking this, particularly those of childbearing age, it's important to have contraception use to really reduce the risk of any embryo fetal toxicity. So lineberger versus placebo without deletion 5q, phase 3, and this is a 005 study, 239 patients with non-deletion 5q and ineligible for or refractory to ESAs. The results were significantly more patients achieved red blood cell transfusion independence that were greater than 8 weeks with lineberger versus placebo, and that was significant. And so that's the key point here we want to show you, that the 26.9 versus 2.5. Phase 3 ECOG study of lineberger plus EPO alpha in MDS, non-deletion 5q to refractory to erythropoietin. This was a phase 3 trial, randomized patients with lower intermediate risk by scoring. And so these were people who were symptomatic with anemia. And with the lineberger, they had 8 events and 11 responders. And then with the lineberger EPO line, 14 events and 28 responders here. What about your low-dose hypomethylating agents in lower risk MDS? What's the response rate? So here we say the strongest predictors of response included bone marrow blast greater than 5%, if they have a diagnosis of MDS or CMML, if they have a high MDS score, and if they have an intermediate score of the IPSS. What about oral azacitidine in lower risk MDS? Phase 3 trial of oral aza versus placebo in lower risk MDS with transfusion-dependent anemia and thrombocytopenia. They had 216 patients. Primary endpoint was red blood cell transfusion independence greater than 56 days. They did find significance here. The median duration of transfusion independent was 11.1 months versus 5.1. So people were able to maintain their blood cells during this time. And so the most common adverse events were low-grade GI events, and grades that were greater than 3 were those who had oral azacitidine. So here we're going to look at lower MDS as well and the telomerase inhibitors. So EMBARK was an open-label, single-arm phase 2 trial, transfusion-dependent in 57 patients. So this was a double-blind phase 3 trial, and it showed that 170 people were accrued. Primary endpoint was looking at transfusion as well, greater than 8 weeks, and median duration transfusion independent was 65 versus non-deletion 5q 85.9. So what are the nursing implications for these different trials, and how do we treat these patients with lower risk MDS? So what's the role of the nurse? Role of the nurse is to manage anemia. And so ESAs are important in blood transfusion, important to manage fatigue, so to cluster the care and the activities that these patients are doing in their home or in the community. They will have some weight loss, and so encourage them to eat high-calorie foods, to drink things that are high and rich in calories. And we also know that iron chelation therapy is also something that's important. So we need to avoid iron supplements or multivitamins with iron. With the number of red blood cells that they will be receiving, we know that they have a higher risk of iron overload. So what's the role of the nurse and caring for also the patient and the family? And so it's important to include them in all discussions and really each encounter that you have with them about the risk of myelosuppression. We know that their bone marrow is going to continue to become more deficient, and they're going to be more likely to have some myelodysuppression. And so it's going to have an impact on their social activities and the things that they really enjoy. So it's important to think about psychologically how that's going to impact them. They may start to have the blues or may start to become very anxious. And so it's important to talk with them about this and to potentially refer them to team players, such as maybe a comprehensive cancer support program referral, maybe to someone that they can help them manage this overwhelming, really loss of control and social activities.
Thank you very much, Dr. Bryant, and thanks to you, the listeners, for joining us. As a reminder, to view the full program, NEDTalk 2021, Current Therapeutic and Supportive Care Strategies for Myelodysplastic Syndromes, and to download the associated PDF from the Clinical Care Options website, please click on the link in the show notes. As always, thanks for listening.